All right, hi, I'm Susan Slycord. I am the current Hospice and Palliative Medicine Fellow at the University of Iowa Hospitals and Clinics. I also did my internal medicine residency training at Iowa. And prior to that, I went to medical school at Des Moines University and did my undergrad at Drake. Additionally, starting in July of 2017, I'll begin an additional fellowship in hematology and oncology here at the University of Iowa. So I think all of that together is kind of why they chose me to give this particular talk on cancer screening, detection, and management in patients with dementia. Okay, so for question one, if I say I have a type of cancer in my breast, a screening mammogram is guaranteed to find it. So, of course, this is false. No screening test can guarantee that a cancer will be found. They all have their limitations, and that's true in all things in medicine and in life, right? There's really no guarantees. So, for a mammogram, the denser the breast, the more likely it is that the cancer will be hidden by tissue, and normal breast tissue can even hide a cancer or mimic a cancer. So often other imaging methods would be needed for a woman after having a mammogram, and for colonoscopies. Often they can detect the cancer, but it's how good they are essentially is highly dependent on the quality of the prep. So, none of them are guaranteed. Okay, next question. There is no harm in routine cancer screening tests. And this one is also false. So studies have shown that as many as half of healthy women who receive false positive test results for breast cancer will receive false positive results for breast cancer after 10 years of routine mammogram tests. So remembering a false positive occurs when a diagnostic test tells you that you have a particular ailment, but in all reality you do not. So most in the false positive group will have to undergo a more detailed imaging scan, and a significant number of those people will also need to undergo a biopsy, and then not to mention all of the anxiety and kind of psychological distress that goes along with waiting results, because that takes often weeks for all of those things to finally happen, and then in the end it might be that there's actually no cancer there. So really, basically, the more screening tests for different kinds of cancer that an individual undergoes, the greater likelihood of having a false positive result at some point along the road. Another study found that half of all people who received at least 14 tests for some combination of prostate, lung, colorectal, and ovarian cancer had been given a false positive result at some point along the way. And men and women with false positive tests have a 1 in 4 chance of having to go a surgical procedure. So that kind of all goes along with, there certainly are some harms that are associated with routine cancer screening. The last question, I had a normal mammogram last year, so I don't need another one this year. So for that one, it's kind of in between. So the fact here is that mammograms are a form of detection, but they certainly are not a form of prevention. So, in the general public, just because you had one in the past, it doesn't mean it's going to prevent cancer from occurring. You need to continue to do them if you're going to find a cancer. But the middle ground, kind of for the check mark there, is that we need to remember that we're looking at the whole person and take into account all of their medical and psychosocial needs before just sort of blanket recommending cancer screenings year after year to all of our patients. So with that, some of our objectives, or our objectives for today, we're going to define cancer screening and detection, discuss patient, physician, and caregiver attitudes regarding cancer screening, and that will really be the bulk of the talk, because that's where I was able to find most of the evidence out there, and then hopefully have a better understanding of the role of prognostication in deciding whether to continue cancer screening or not. And ultimately, with those first 3 objectives, we'll sort of accomplish the goal to stress the importance of individualized cancer care and shared decision making in patients with dementia. And I'll tell you up front, that's the take home of this entire talk, is that we need to do individualized cancer screening and cancer care for patients with dementia. So overall, I didn't find a ton of published evidence about this topic. There's one group at Indiana University that's probably done the bulk of the work. as far as looking at attitudes towards cancer screening in the specific target of dementia patients. So we will discuss their work along with a few other studies that looked more at the general attitudes in our country towards cancer screening in the overall population. So like I said earlier, I think the overall majority of this talk will focus on cancer screening because that's where I found most of the evidence, but general attitudes towards screenings can easily be applied to cancer detection and management as well. So it really is sort of along the whole cancer continuum. So my disclosure statement, I really don't have anything to disclose. So to get started here with cancer screening, by screening, your goal is to detect cancer before symptoms appear. So this may involve blood tests, some urine tests, other tests, sometimes imaging. The goal, like I said, is hopefully to lead to an earlier diagnosis. One point to make is that it is important to remember that when a doctor is recommending a screening test, it doesn't mean that he or she thinks that the patient has cancer. If there were some other indication or some symptoms that were coming up, it really wouldn't be a cancer screening anymore. Then we would be looking more to detect, and we'll touch on that a little bit more. So the kind of other end of the spectrum on that would be foregoing screening at an older age doesn't mean that the patient is dying or wishing for death or that the doctor thinks that the patient is imminently dying either. So screening tests certainly do have risks, like we talked about with one of the questions at the beginning. They can cause some serious problems. One that comes to mind would be with colorectal cancer screening. With colonoscopies, there is a risk of having a colon perforation, probably the more common risk, especially in the geriatric and dementia population, would be the risk of potentially having severe dehydration with the prep for a colonoscopy. So those are all things that we have to take into account. We certainly touched on the fact that false positive results are a possibility. There's certainly false negatives that occur as well. And then finding the cancer may not actually improve the person's health or help the person live longer. So then you've sort of done a test, put the person through the risk of it, and really for no net benefit. So positive screening results are usually not diagnostic, but identify people that are increased risk for the presence of cancer who warrant further evaluation. So we've touched on that a little bit already, that often, the mammogram leads to a breast ultrasound or a breast MRI that leads to a biopsy that then you finally figure out what you're dealing with. So it's usually sort of the beginning of a chain of events that are going to continue. And then the benefits of screening in terms of cancer prevention, early detection, and subsequent treatment must all be weighed against the harms. Things that are involved in cancer screening, it may be through direct or assisted visual observation, palpation procedures such as endoscopies, or imaging modalities like x-rays, MRI, or ultrasound. Lab tests like a pap smear or fecal occult blood test are all or something sort of like a fecal occult blood test to detect colon cancer, all different ways. So some more invasive than others, certainly. So the most common breast cancers common type of cancers that we're usually looking for are breast, colorectal, cervical, and prostate cancers. With prostate being more controversial of late, and we'll talk about that a little bit later. So these images that are on this slide, they're just taken from Google Images. I always find it interesting to sort of click on the Images tab when I'm Googling something, especially for a talk. It's a really good way to sort of see what the public perception of an issue is. So for all of these cancer screenings, the overall kind of theme is a lot of bright colors and ribbons and cute little funny cartoons. Overall, the images are certainly positive ones, with sort of the take-home that our society is definitely kind of pro-cancer screening, and have really jumped on the bandwagon. The public service announcements and the more you know bits have really worked. People are all for cancer screening. So the other part of that, or going along with that, is cancer detection. So a cancer may be detected by screening in an asymptomatic patient, but other ways cancers are detected are with symptoms. So if somebody comes to their doctor with complaint of cough or maybe of hemoptysis, then that that starts a workup essentially to try to detect the cancer. So maybe they get an x-ray, and then they get a CT scan, and they find out that there is a spot on the lung and it's lung cancer after kind of another string of events. And then another way that cancer is often detected is sort of what we call incidentalomas. So cancer that's found on imaging for another reason. So let's say that same person comes to the ER because they've had a bad cough, and they get a chest x-ray, and there's something on the chest x-ray, but they're not quite sure what it is. So then they get a CT scan of their chest, and it looks like pneumonia. So, whew, no cancer, we're good there. Oh, but wait, what's that on the kidney that we sort of got in part of the CT scan? So nobody complained of any problems with urinating or any back pain or other kidney type issues, but the CT scan for something else found this new kind of development on the kidney. So those are what we consider as incidentalomas. Common ones are actually more like adrenal gland or lung nodules can be found this way. So cancer detection may also require additional blood tests, imaging procedures, and biopsies, just along the same lines as cancer screening. So now we're going to get into sort of the meat of the talk. So we'll start with patient attitudes towards cancer screening. So there was a study by Schwartz and others who performed a survey to determine the public's enthusiasm for early cancer detection. This was probably the highest powered of all of the papers that I was able to find. So they had an N of 500, and this was the general population. So this was not specific to dementia. But they included women at 40 or older and men at 50 and older. I'm sure they picked those ages just for those are kind of the typical starting points of when we do breast cancer screening in women, and then 50 for colorectal cancer screening in both, and maybe PSA for prostate cancer at 50. They must not have included cervical cancer as a routine screen in this, because that you would be starting at 21. So anyways, with this survey, they found that 87% of adults believe that routine cancer screening is almost always a good idea, and 74% said that finding cancer early saves lives most or all of the time. Less than a third believed that there will ever be a time when they would stop undergoing routine screening. So, when I hear that, it kind of just makes me realize how nearsighted we are in medicine sometimes, that we love to start things and try new things, but have kind of often failed to think about when we would stop doing something. And so if we don't bring it up, based on some of these results, it doesn't look like the general population is going to bring it up. So going along some other findings of this study, they sort of gave the example of an 80-year-old that chooses to not undergo screening, and what are the attitudes towards that. So if the specific screening was mammography, 41% felt that decision was irresponsible. And if it was a screening colonoscopy, 32% felt it was irresponsible. 38% of responders had experienced at least one false positive test. And they described this as being very scary or the scariest time of my life. And still, looking back, 98% still said that they were glad that they had that initial screening test. So even though it was the scariest time of their life, they were glad that they did it. Most had a strong desire to know about the presence of cancer, regardless of its implications. And overall, this has been a fairly common theme, at least in my hospice and palliative care training thus far. I've found now to ask that question, at least, of people. Do you think it's important to know for you if you have cancer or not? Some people say, no, if we're not going to do anything about it, I don't really care if I know or not. Other people may have other reasoning for saying that they do want to know. Maybe they want to know so it starts a family history of whatever cancer, so that their daughters and their granddaughters can start looking for cancer earlier. And then 2/3 of those surveys said that they would want to be tested for cancer even if nothing could be done. So in this group, that was more of the theme than the other way. Additional findings from this survey. So 56% said that they would want to be tested for pseudodisease. Pseudodisease is cancer that's growing so slowly that it would never cause problems during a person's lifetime, even if untreated. And to me, that was somewhat surprising. So I think it just goes more towards this kind of general attitudes about being very pro-screening in our society. And then this last one was sort of absolutely shocking to me, I guess. So 73% of survey participants said that they would prefer to have a total body CT scan instead of receiving $1,000 cash, which is, I am definitely not in the 73% on that. So, the overall takeaway from this survey is that there's a clear enthusiasm for cancer screening in the U.S., and the scary part of that for me as a physician is a definite increased risk for over-testing and over-treatment in the general population, and then I think could easily infer in the geriatric world and in dementia patients. So another paper that I found was from Torque et al. They interviewed 36 older adults in their paper that was entitled "Older Adults and Foregoing Cancer Screening. I Think It Would Be Strange." So their group was a median age of 76, so certainly an older group, with a range from 63 to 91. 27 of them were women, 15 African American, 16 white, 1 Asian, 1 American Indian. And they went about performing these interviews by recording them and then transcribing the audio recordings of the interviews, and then subsequently analyze them to identify certain themes and illustrative quotes. So their findings, some common themes that they found, the people were saying that they feel a moral obligation to undergo screening. So an 84-year-old woman described the choice between stopping and continuing screening, and she said, "I think I should, because stopping would be the same as taking my life, and that's a sin." Another theme was that cancer screening equated to health and life. And so another person said, "I know that I need that done because I love my life. I want to live." Another theme was that screening is not a decision, it's just done automatically. So whenever we were told we were supposed to do something, I just, did it. And continued screening just occurred as a matter of a routine habit. So either a physician prompt, a form letter gets sent, or some other type of a brief reminder. And I know that happens with our electronic medical records, that things sort of pop up. This person needs this now, they're due for this. And sometimes they get sent without thinking much about it. A 75-year-old woman said that she decided to have a mammogram because I was getting them every year. So not thinking too deeply about it, just I've always gotten them, I've been getting them, guess I'll keep getting them. And then others went along with the plan for screening, kind of with little discussion or understanding of the purpose of the test. So the interviewer asked, "And what went into the decision to have the mammogram done?" And the participant says, "Well, I'm not sure, other than it was a good thing to have on record." So we certainly don't want people to just be kind of checking boxes when it comes to cancer screening, something that does have some risks involved. Want to be thinking about it a little more. So another theme was when physicians recommended continuing screening, patients generally accepted that recommendation without really any further questioning or discussion. So one participant said, "Doc said I needed it, and I told them, go ahead and do it." And then there was limited communication about screening. So many said that they never discussed stopping screenings with a physician or considered stopping them on their own. And the few that did recall discussion occurring, most of them said it was quite brief and contained very little information. So one blurb, an interviewer said, "Can you tell me more about what the doctor said the last time you made a decision about a cancer screening?" The participant said, "Just recommended a mammogram." "Did you discuss the benefits of the harms of the test?" "No." "Was there anything the doctor said or did that you found especially helpful?" "No, not really. Just seemed unconcerned and just a typical test." Another example was an 83-year-old woman that described accepting her physician's recommendation to stop screening mammography. So it's sort of the other end of the spectrum. So this patient said she just looked at my paper and said she didn't think I needed them anymore. So only one patient whose physician recommended against screening because of age was upset by that recommendation. So I think this paper goes to show that we just need to have more open dialogue about it, and communicate a little bit more, and probably have this be a discussion that maybe is one where you sort of drop a few seeds early on and then come back and revisit it again, instead of just making it feel like it's an abrupt change that's happening in the patient's care. So they did look at potential factors in decision making, and the themes they found here were active discouragement of screening by physician, the use of government panels in the discussion, the use of statistics in the discussion about screenings, and then weighing burdens and benefits. So we're going to go into each of those a little bit more. So when the physician actively discouraged screening, many participants said that they would question that recommendation or perhaps even seek a second opinion. Some participants expressed disbelief that a physician would ever recommend stopping cancer screening. So clearly, some of them have never had any of these discussions. As far as government panels go, there were many negative responses to recommendations from experts on government panels. And they noted that it just seems like they're constantly changing. And I've got to say, in my young medical career, I agree with this in some ways. It can be hard to keep up. For example, the USPSTF, kind of one of the governing task forces on preventative services, just recently came out a few weeks ago here in April about maybe like a new draft recommendation regarding PSAs for prostate cancer screening. So back in 2012, the USPSTF recommended against prostate-specific antigen or PSA-based screening tests for prostate cancer. Like blanket statement, just don't do them. And so that was when I was still in, what was I in? Medical school, I think then. And so I kind of, in my training was just don't do PSAs. They cause more harm than good. Well, so now here in 2017, they have this draft recommendation that now they're sort of breaking it into age groups. So maybe for men age 55 to 69, they use the terminology that clinicians should inform men in that age group about potential benefits and harms of PSA-based screening for prostate cancer. That screening offers a small potential benefit of reducing the chance of dying of prostate cancer. However, many men will experience the potential harms of screening, including those of false positive results, like we've touched on quite a bit, and that they may require additional workup. Overdiagnosis and overtreatment are also potential risks, along with treatment complications like incontinence and impotence. So they then said, I think that they, for men that are 70 and older, they still do recommend against PSA screening in that age group. So certainly something to think about, I guess. One of the participants had a quote that she just said more, I've heard so much about the government changing their minds on this. Just like, for example, coffee's not good for you, and then coffee is right for you, I don't have too much faith in some of them. So I think that one's fairly easy to see where people are at with that. Somewhat similarly, using statistics to talk about cancer screening didn't really sit well with most of the participants. So they felt like it wasn't relevant to individual decision making. Someone said, I would not consider myself part of the statistics, and I think that each individual person is different. Others expressed optimism that even if the chance of benefit was low, they might be the one to benefit from the test. And this is certainly something I've run into, again, with my palliative care training this year. Some people are numbers people, and other people are not at all. So it is helpful to ask people, do you think hearing some of the numbers or some of the stats would be helpful for you or not? By asking that question, you might save yourself a lot of time too. It's just, I think often in medicine, we are all numbers people, and we like that, and I think we get some comfort in numbers, but I think we have to remember a lot of our patients aren't that way, and it just sort of confuses things and maybe creates more of a gap between us. And the last part was talking about burdens and benefits. So many of them expressed that they would be convinced to stop screening owing to the burdens of the test if that outweighed the benefit. So one participant said, I don't want to, mainly because I don't like that stuff you have to drink and the fact that you have to spend so many hours on the toilet. So obviously this person is not a fan of colorectal cancer screening at all. And that's, depending on where they're at in their life, that's their their choice to make. So overall, I think what we could take home from this paper is to frame the conversation in terms of increasing burdens in relation to benefits, and that may help to maintain and promote trust. And probably try to avoid citing statistics about the patient's likelihood of benefiting from the test or using national guidelines regarding cancer screening. Public health education and physician endorsement has created quite a high degree of momentum for continuing screening, and so we have to, like I said earlier, kind of gradually address this topic. Maybe over time would also be a helpful way. So now we're going to move on to physician attitudes towards cancer screening. I didn't find a ton about this that's published anyways, but there was one paper by Wegworth and others that looked at physician understanding of cancer screening stats. So, if we're going to be talking about this with patients, do we really understand quite what we're dealing with or not? This had quite a few people participate in this as well. So initially they had 297 physicians that worked in both inpatient and outpatient complete a survey in 2010, and then 115 physicians that were strictly in the outpatient world did the survey in 2011. Physicians received scenarios about the effect of 2 hypothetical screening tests. So they gave 2 options. So option A, let's say whatever type of screening test this is, it improved the 5-year survival and increased early detection. Or option B, the same tests, you say it decreased cancer mortality and increased incidence. Which option, A or B, which effect would you choose to say that is evidence for the benefit of the screening? So we're going to talk about that a little bit more. So here you can see kind of the fundamental problem of survival statistics in the context of screening is that they are susceptible to lead time and overdiagnosis biases. As a result of these biases, changes in survival can be observed without any change in mortality. And so these figures kind of show how both of these biases work. So first we're going to talk about the top one with lead time bias. So imagine a group of patients in whom cancer was diagnosed because of symptoms at age 67, all of whom die at age 70. Each patient survives only 3 years, so the 5-year survival for the group is 0%. Now imagine that same group undergoes screening. Screening tests, by definition, lead to an earlier diagnosis. Suppose that with screening, cancer is diagnosed in all patients at age 60, but they nevertheless die at age 70. In this scenario, each patient survives 10 years, so their 5-year survival for this group is 100%. Yet, despite the dramatic improvement in survival from 0%, from nothing, to 100% 5-year survival, nothing has actually changed about how many people die or when. So if you look at that, I mean, you can certainly, I think the graph helps. I'm not a statistics person at all. I'm not that person in medicine. So I thought hopefully the graphs kind of help bring it home. It did for me anyways. So the bottom half of the graph deals with overdiagnosis bias and how it can distort survival statistics. So in this one, we're going to imagine a population in which cancer is detected because of symptoms. And it's diagnosed in 1,000 people, and that 400 are alive in 5 years. So that's a 5-year survival rate of 40%. Now imagine that the population has undergone screening. Screening can detect cases of cancer that are not destined to progress, what we call overdiagnosis. Since these cases of cancer are non-progressive, these patients will survive 5 years. The addition of the overdiagnosed cancer patients distorts the 5-year survival statistic by inflating both the numerator and the denominator. So in this one, we think there's 2,000 cases of cancer were overdiagnosed. After 5 years, 2,400 people will be alive out of 3,000 diagnosed, an 80% 5-year survival rate. But again, despite the dramatic improvement in survival from 40% to 80%, nothing has actually changed about how many people die or when. So what do you think about your answer back on this slide? So would you choose A or would you choose B on what you've heard now? So I think you should choose B. So in contrast to survival and early detection rates for cancer, cancer mortality rates are unaffected by lead time and overdiagnosis bias. This is because mortality statistics simply divide the number of deaths from cancer by all people in the study population. Mortality statistics are not distorted by the timing of a diagnosis because all deaths that occur in the study population over a given period of time are counted. Because lead time and overdiagnosis biases do not affect mortality statistics, the National Cancer Institute were able to conclude essentially that reduced mortality in randomized trials is the only statistic that reliably proves that a screening test can save lives. So if you got that wrong, you weren't alone, and that's what this test looked into. So they found by surveying these PCPs, by giving those two scenarios, they found that primary care providers were more enthusiastic about the screening test that was supported by irrelevant evidence, the 5-year survival rate increasing. Fewer supported the test presented with the relevant evidence that the cancer mortality could be reduced. And about 1/2, 47% of physicians incorrectly said that finding more cases of cancer in screened versus unscreened populations proves that screening saves lives. And that's just not true based on what we've learned about statistics now. So overall in this study, most PCPs mistakenly interpreted improved survival and increased detection with screening as evidence that screening saves lives. Providers need to have a better understanding of kind of key cancer statistics in order to answer patients and their caregivers' questions about effectiveness of cancer screening and to help assist in informed decision making. Another part that goes with, I think, physician attitudes is the role of prognostication in cancer screening recommendations. So clinical practice recommendations are increasingly advocating that older patients' life expectancy be considered to inform a number of clinical decisions. I think in any busy clinic day, you're probably not routinely thinking about life expectancy of every single one of your patients, and you probably don't need to. But when you're thinking about things like cancer screening or some of the other things that start to feel very routine, as a patient gets, or their life expectancy gets shorter, you have to start thinking about, should this be something that's routine anymore, kind of, or not. So Schonborn and others looked at PCP views on incorporating long-term prognosis in the care of older adults. And I think this is important to the topic, especially with dementia. So dementia can be hard to prognosticate. You know, we've all had patients that from the time they were diagnosed to the time they died was a very short period of time, sometimes only a year or two, or even less, but other people seem to really kind of hit a plateau and stabilize for many, many years, and so it can be hard to estimate that. But so in this paper, it was a qualitative semi-structured interview study. This was a large group practice with settings in rural, urban, and suburban areas, and they were able to interview 28 PCPs. They were able to identify 5 major themes. So long-term prognosis considered in several clinical scenarios, prognosis considerations balanced against other factors, prognosis assessed based on clinical experience, discussion of long-term prognosis, and barriers to incorporating prognosis. So we'll go through each of those kind of individually. So as far as long-term prognosis being considered in several clinical scenarios. So in addition to cancer screening, PCPs mentioned other times when they considered a patient's life expectancy, and they often identified it more in ranges, so like 5 to 10 years. So other types of preventative care decisions, if there was the presence of a life-limiting condition, they were thinking about long-term prognosis, or maybe short-term prognosis too, and then presence of multiple serious chronic conditions. The next theme was prognosis considerations balanced against other factors, so patient preference. So one physician said, do I give in sometimes and do tests that I don't think are medically necessary? Yes. If the patients insist, I say, okay, as long as you understand. And then also balanced against age and nature of prognosis. So they did sort of find a theme that in patients who were younger and had poorer long-term prognosis, probably mostly just because of age, the PCP were still likely to continue aggressive preventative care unless the prognosis was poor over an even shorter amount of time, like weeks to months. So one PCP said, I would feel very uncomfortable for a 50-year-old patient saying, we'll never screen again for colorectal cancer, even though I would be shocked if they live longer than 5 years from now. So that's just kind of an interesting view. And then they also said there's certainly a fear of making a wrong estimate of prognosis. I think this is certainly true for patients with dementia, especially knowing there's so many different factors that weigh on that idea of how much time is left. So for somebody with dementia, if you tell them that you think they've got something closer to 7 to 10 years to live, they're probably going to try to stay at home longer, potentially anyways, conserve some of their resources, versus if you tell someone you think they only have 1 or 2 years, that might help the person and their family or caregiver to decide that sooner rather than later would be the time to move into some type of a care facility. But then if you're wrong, they may not be able to stay at that care facility because of finances. So there certainly is a fear of providing the wrong prognosis. The next was prognosis assessment based on clinical experience. So overall, the PCPs in this group anyways were pretty unfamiliar with prognostic tools. And I would say before starting this palliative care fellowship, I wasn't using a whole lot of prognostic tools myself. So that one didn't strike me that much. They sort of said that PCPs often use their gestalt sense based on clinical experience, which is sort of how it felt or how it seemed like things would go. And their assessment approaches varied, so many of them relied predominantly on age, others focused more on functional status, and others seemed to gravitate towards specific life-limiting diagnoses as far as how they were assessing prognosis. Overall, the time frame of their prognostication varied greatly, from 2 years to 20 or 30 years for some patients. Another theme was discussion of long-term prognosis. So responses varied on whether or not to discuss prognosis, when to discuss prognosis, going back to whether or not to discuss prognosis. One physician said, I have to say, prognosis is something I go through in my head, but it's not necessarily something I say to the patient. So I would say that it's infrequent, that it's a verbalized discussion. So I thought that was interesting to hear, because I think, that's some of the, especially like on inpatient medicine or really in outpatient too, like, so what's being said like in the teamwork room versus what's being said in front of the patient. And then, let's see, so when responses varied on when to have the discussion about prognosis, kind of earlier versus later. So one physician that seemed to favor earlier said, I think there's a huge benefit to doing it earlier. The sicker you get, the less clear things are. Having those conversations and revisiting them often, the sooner the better. I would say that's probably more in line with palliative care and how we view about things. But another PCP favored having discussions later, and they said once they go into the hospital on a ventilator, getting IVs, it's easier to have that prognostic discussion because you can see it and the patient can feel it. If they just walk into my room, they can't see it like they can when they're sick. And I think there's certainly some truth to that too as well, but I think overall, at least from a palliative care standpoint, we would still advocate for having discussions earlier, but realizing that hopes and values change as a person gets sicker, and so decisions are never in stone, and people can still change their mind as things change. There also had varied responses on the comfort in discussing prognosis and frequency of those type of discussions with patients. So as far as discussion strategies, some of the PCPs gave a few different insights. So one talked about more like asking the patient to estimate their life expectancy first, and then use that estimate as a starting point. So that sort of reminds me, like in medical school, they would always say, like, the patient the patient knows what's wrong with them. And so I remember one of my preceptors would always say, like, there's nothing wrong with asking them what they think is wrong with them. So certainly if they're like, well, this feels exactly like the last time I had a sinus infection, like, there you go. You probably figured it out a lot faster than going through sort of your normal run of questions. Not that you shouldn't still do that, but the patient can help you out. So I think that's similar to what they're saying. So she said, how long do you think, or this is what she would say to the patient, how long do you think you're going to stick around? And then they'll tell you, and you say, okay, if that's what's going to happen, then you probably won't need a statin because the benefits aren't large enough to outweigh the risk at this point in your life. So that's one way kind of starting this discussion. Another one, or another topic or sort of way of getting into this that the paper discussed was to frame the patient's life expectancy in context of how it would be affected by an intervention or a diagnosis. So the example they used was, this new diagnosis has significantly altered what we think your life expectancy will be, and we need to use it as a touch point, not only for this disease, but for other things on how they're going as well. So I like that one. And then the last one, can't say I've ever really used this, but talking about kind of incremental ranges of timelines to guide the patient to think about their life expectancy. So the example from this one of the PCPs said, it's unwise for you to not consider that you're not going to be here 20 years from now. Most people, if you pick a far enough time, for example, like if they're 80 and you say, look, I'm not worried about how you're going to do 25 years from now when you're 105, and they think, oh, ha, 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 ha. So then you can start to bring them back. But what about when you're 100? What about 95? What about 90? And then they start to realize that there is a point and when I need to start thinking about some of these things. Some common sort of barriers that were identified to incorporating prognosis. There was a bunch. So uncertainty in predicting prognosis, we've kind of touched on that already. Difficulty in discussing prognosis. Time constraints in clinic visits. Lack of emphasis or value placed on prognosis in societal or healthcare culture. Inappropriate incentives in the practice environment. Concern for litigation. Inadequate training on how to incorporate prognosis, and concern about patient reactions. So PCPs were certainly concerned that patients may perceive the PCP as being judgmental or abandoning patients if the prognosis is considered in clinical decisions. One PCP said, I'm afraid that the patients will think I'm going to give up on them, like I'm not doing anything anymore. I feel like I'm playing God, is what one PCP said. So that was an interesting perspective. A few of the facilitators to incorporating prognosis, or themes that they found, were knowing the patient well over time, and knowing that the patient had previously considered or discussed prognosis. So the last group we want to look at is the caregiver attitudes towards screening. So Tork and others, in their paper, Caregiver Perspectives on Cancer Screening for Persons with Dementia, Why Put Them Through It? This was a group that was part of the Alzheimer's Association support group for family members of individuals with dementia. They formed 4 focus groups of 32 caregivers. You can see the demographics there. Again, mean age of 65 and a half. And they used the transcripts from focus groups they analyze them with methods of grounded theory, again looking for certain themes and illustrative quotes. So again, this is caregivers. Several themes emerged with the caregivers. So discussing about quality, not quantity of life, increasing burden on patient and caregiver, intervening to stop screening, and variability of physician expertise. So most of this is going to be quotes because I think it's the best way to kind of illustrate where some people are at. So as far as the theme with quality, not quantity of life, a caregiver said, I was concerned about her quality of life and making sure that she was very, very comfortable. And I think that means more than putting people through a lot of unnecessary, uncomfortable procedures. It's not going to make the person better. It might make them linger on, but are you really living? And another caregiver said, I believe at a certain point it's a form of torture if the person really hasn't chosen it for themselves and you aren't significantly extending their quality of life. As far as increasing burdens on the patient and caregiver, a caregiver said she absolutely would fight it tooth and nail because not really understanding exactly, and also the older she gets, it seems like the more she responds to any kind of discomfort. Getting her shots now are a problem. Getting blood from her is now a problem. There would be no way we could do a mammogram. Another one along those lines, a caregiver said, I asked the doctor, okay, if you find something, what would you do? And he said, well, it would be the normal progression of going through surgery. I just looked at him and said, do you think my mother could survive surgery? And he said, no. And that was my decision right there. And then as far as intervening to stop screening, a caregiver said, I'm in charge of my father's medical care now, but I wasn't when he had his last colonoscopy. It was from that experience that made me pursue that I had to take over, because he was sent a letter from this place saying that it's time to come in again, and he and my stepmother just said, well, the doctor says it's time to go again. When she got him home, he could barely get up their apartment stairs, and I thought, this can't happen again. And another one about intervening to stop screenings. My mom hasn't had one in eons, but her doctor asked her to have one earlier this year, and she said okay. But I asked, why are you ordering this now? She's 88. Tell me, what's the point? He said, it's just been a long time. Let's do it once just to make sure that she gets a clean bill of health. I said okay with respect. And then another theme was sort of the variability of physician expertise as far as the caregiver's attitudes towards screening. So the first one, a caregiver said, I don't know whether at this point I should change primary care physicians, but she clearly doesn't know about Alzheimer's, and she is clearly not helpful. On the other side of things, another caregiver said, we had a wonderful experience with our primary care physician. She said, Alice, you're 85. You don't have to do anything if you don't want to, but here's what I would do if I were you. And it was such a relief to know that I wasn't subjecting her to anything she didn't want, and I wasn't going against medical wisdom either. So kind of more of that open attitude in that last quote. So overall conclusions about caregiver attitudes towards screening. Caregivers of people with dementia are willing to consider stopping cancer screening. Many are relieved when the physicians bring it up. And then we should try to focus the discussion on quality of life and balancing benefits and burdens. And I think to remember not just burdens to the patient, but to the caregiver as well. As anybody that's taking care of patients with dementia know, it's just as hard, if not harder, on the caregiver than it is the patient. And then also reducing unnecessary screening has the potential to reduce patient burden, costs, and caregiver distress while improving the overall quality of life. So here in another paper, I found sort of a little bit of a decision-making model or kind of an algorithm to help with decision-making. So up at the top, you start with advanced dementia, question mark. So if they have advanced, it's saying don't do mammography. And I think you can apply this probably to any type of cancer screening, not just mammograms. But if you say no, so mild or moderate dementia, do they have significant comorbidities or a life expectancy of less than 5 years? And so that's when it can get a little tricky. Because there are certain patients that have dementia that's really all that they have, and they've been pretty healthy the rest of their lives, and so sometimes it can be hard. But I think this is sort of the decision point with having more open-ended discussions and talking about risks and benefits and burdens will help. But so if they don't really have comorbidities and they have like kind of maybe just really mild dementia, it asks, is the patient able to understand the risks and benefits? And if yes, then talk through them and sort of review it and make the decision together. So that's sort of that shared decision making. So kind of their overall, this pretty much summarizes just going through the chart. Families of patients with severe dementia should be advised that screening mammography is more harmful than beneficial. Like I said, you could probably say colorectal cancer screening, prostate cancer screening. You could probably infer that. This is pretty much summarizing what I said. Again, just remembering to kind of consider benefits and burdens to pursuing a definitive diagnosis. Overall, though, so like I said, most of the talk has been focused on cancer screening because that's where most of the evidence I could find was. But I think in somebody with dementia, if you detect cancer, that's a kind of a stop point to have a bigger discussion. I can say, at least from my time with working with hospice this year, I probably had the perception that if an elderly woman with dementia got breast cancer, she would suffer from her breast cancer. But based on a few hospice patients I've seen, I don't know if I would agree with that anymore. There was a lady I saw that had developed kind of a fungating wound on her breast, and they initially treated it with some antibiotics, and maybe there was some minimal improvement in the drainage, and it wasn't necessarily as erythematous around it, but it didn't really change in size. And then the next week it seemed a little bit worse again, and ultimately that led to kind of the presumptive diagnosis of an inflammatory breast cancer. For her family opted to not pursue any further workup or diagnostic tests or imaging, because they felt like putting her through all of that at this stage in her dementia was still going to cause more harm than good, and for her to be told that she has breast cancer was going to be really psychologically and emotionally damaging for her. So for her, with excellent wound care by the hospice agency and in the nursing home where she was living, there really was no evidence of it, and it didn't look like the patient suffered in any way. So for me anyways, it was a way to sort of see that somebody can be living with an advancing cancer but not necessarily suffering from it. So they really were able to maintain her dignity, and she ultimately died, less than a month from when I met her, due to her underlying dementia, not probably from her cancer. And so kind of that last bullet point, what will we do once we know the diagnosis, is always a good thing to ask before just pursuing things. To me, that again sort of reminds me of in medical school, always, if you're going to order that lab, what are you going to do with it? And if you can't come up with an answer of what you're going to do with it, then don't order the lab. And so I think, that's a basic example, but I think it's similar. So if we're doing screenings, if a person would never want to have surgery for a breast cancer, then why go looking for it? And that's sort of the same, that just because it's detected, it doesn't mean it's going to be really aggressive, or maybe it does, and that by having an open discussion with a family, they can say, perhaps, dying from whatever cancer may be a better death than dying from dementia, and that's a discussion that deserves to be held. So overall, conclusions: consider the life expectancy and overall prognosis, and discuss with patients and their caregivers prior to making recommendations for or against cancer screening. Cancer screening, detection, and management often result in increased burdens in patients with dementia. And then really the whole take home is, if you remember nothing else, we should be doing individualized rather than age-based decisions when it comes to cancer screening. So here are my references here over the next several slides. And thank you for your time. It was a pleasure to do this with the Geriatric Learning Series. And if you have any questions or comments, my email is there, and feel free to email me. Thank you.